we turn on the recording. So here we go. Okay,
So
go for it.
is this looking correct on your end?
Yeah.
Okay.
It looks like you have the, it's not the whole slide. It looks like you have the next slide.
Oh, shoot. How
I'm
do
not
I
sure.
get it to work the right way?
I'm not sure. Okay, that, do that and do slideshow. Over here, slideshow,
Slideshow.
right there. So plan from start, play from start, right there.
May want to do view too, because you had presenters view up there.
That's what I want to see, but how do I get it to show you just this?
No, they're going to
No,
see what you see on the on your screen.
Well, you could do it that way too, but if you go back out and do either this slide or beginner's view, that's how we do it. Yeah, there you go. There you go.
Perfect.
Okay.
Problem is I can't see my notes.
Well, you should be able to see it.
I can't. That's why I don't know how to set this up right.
Well, then
It's-
do it the way you
Sarah.
had it then. Then do the presenter view and just make it bigger. So the way thing you just did. Here you go.
Can you guys see the?
Yeah, we can see it. Mhm.
All right. Well, I do need to disclose that my primary employment is in the cannabis space. So I do derive revenue from it. The learning objectives, you should be able to list 3 medical conditions that cannabis has successfully helped or treated, describe the importance that formulation and route of administration has on the onset and duration of action of cannabis in humans, and list 3 routes of cannabis administration. Really tough objectives. The goal of this presentation is just get you familiar with basic cannabis terminology, discuss general considerations when you're considering a cannabis product or recommending a treatment. I'm going to list some of the most common real-world medicinal uses of cannabis, and then present some published data and case reports supporting a few of those indications. So this is the cannabis leaf on the right, and an example of the finished product called a bud, which is the cured and trimmed final consumable form of the cannabis plant. Today, it's really hard to recognize the difference between hemp and marijuana, hemp being on the right and a marijuana cultivar being on the left. So both plants are cannabis sativa L, which describes the species of marijuana and hemp. The terms are regulatory terms based on the THC content. Marijuana having greater than 0.3 milligrams per gram of THC and the dry weight of the plant. And it's still, as of this day, a federally Schedule I drug, which by definition has no recognized medicinal value and is highly addictive. And hemp having 0.3 milligrams per gram or less of THC in the dry weight of the plant. Congress amended the Farm Bill in October of 2018 and defined hemp and all of its components and extracts a agricultural commodity and legal in states that have approved USDA or equivalent programs, and by default, federally legal based on those state approved programs. Bacteria and fungi have strains, but plants do not. A strain is the layperson's term for cultivar, describing a phenotypically different plant, typically named by the grower based on smell, appearance, and physiologic effects. Common terms used describe sativa as a taller, more slender plant, it generates more of an energetic effect. Indicas being a shorter, squatty plant, and generally provide a more of a relaxing effect. But greater than 95% of the flower market today are hybrids, which are a mixture of the two. Varieties, names for those above 3, respectively, are Jack Herrera, Blueberry, or Catatonic. Chemovar is a term used to describe the actual profile of the plant. And hopefully chemovar will be used as we move cannabis into a more acceptable and reproducible form in medicine. Now, most clinical studies of cannabis in the past focused on the contents of 2 major cannabinoids, THC and CBD, regardless that now we've found over 150 phytocannabinoids. In this heat map from David Miri's lab in Israel, on the x-axis, it's got, it's really hard to see, but it's got 36 cultivars. And down on the y-axis, it's listing a whole bunch of phytocannabinoids. Now, typical testing in the US today, just 2 years ago, was 9 to 13. Now some of the cannabis labs are testing as many as 23 phytocannabinoids, partly because there isn't a lot of standard references, but that is changing rapidly. Probably next year we'll have a bunch more that are available, but the challenge is you've got 10 different types of THC, 10 different types of CBD, and so on. All of these phytocannabinoids are active. They have some physiologic effect, and in certain combinations can really generate a beneficial or not so beneficial outcome in any individual. Now, as of this publication in 2020, there have been over 27,000 published studies since 2020 in peer-reviewed literature. I like the slide because it just describes some of the components of the cannabis plant. It's got some good references. So this is looking at a diagram of the phytocannabinoid acids and their metabolism in the plant. The plant produces phytocannabinoids in the acid form. The mother of all is CBGA. And looking at the 2 dominant phytocannabinoids, THC on the left and CBD on the right, following harvest, decarboxylation is generally performed in some form of an extraction by using an extraction method, but light or heat can change these forms even in the plant. It's remarkable that all of these that there's so much activity with phytocannabinoids, and even a terpene, beta-caryophyllene, is an agonist at the CB2 receptor. Now, there's general terms that can be used to describe extracts: full spectrum, broad, and isolates. The full spectrum is attempting to maintain the full profile of the cannabis plant that was processed. Broad spectrum is trying to attempt the same thing without any measurable THC that's detectable. And isolates are extracts that are generally greater than 99% of a single cannabinoid. The extraction method will determine what components of the plant are able to be removed, and that content varies significantly. CO2 is probably the most common marijuana extraction that's used in the cannabis space in the US, followed by like hydrocarbon. But alcohol and different fatty acid solutions are used, as well as some of the old forms, which are water, ice, and steam. And these produce from the same material a very different, sometimes very different amount and content of phytocannabinoids and terpenes. In the commercial big farming platform, petroleum hydrocarbons are generally used. And in the commercial space for hemp, those are the main methods of extraction. So these are some of the common types of routes of administration that are used. And you can pretty much find cannabis in every pharmaceutical dosage form that exists, except injectable. Inhalation uses both combustion and vaporization. Ingestion, there's a term used, edible, which I like to try and focus as food, candy, drinks, etc. But they're both being consumed orally, whether it's a pharmaceutical dosage form like a tablet or a capsule. Sublingual and buccal means placement in the mouth, both looking for oral mucosal absorption. And then you have topicals, transdermal patches, suppositories, bath bombs, you name it. Many of these routes of administration will avoid first pass metabolism, which is pretty significant, and can have a significant impact on the user's experience. So some general guidelines that we can use looking at the route of administration. Inhalation usually has an onset of less than a minute and a duration of 1 to 3 hours. Looking at the research or the literature, the CP max is generally around 5 minutes. You don't get as much of an anti-inflammatory effect as with any of the other routes of administration, but it's probably still well above 70% of the form that is consumed by US citizens using cannabis today. Edibles and orals generally have a 45 to 4 hour onset of action, and the duration is 4 to 24 hours. It's really dependent on what's in the stomach at the time of administration. And this is where it has such an unpredictable onset and duration for most people. This is where people have had a gummy or a cookie or a brownie, and they didn't get any effect, and they take another one an hour later and they still didn't get an effect, and 4 hours later they've had 4 or 5 servings, and then they get so high they wish they were not high. Sublingual tinctures or fatty acid solutions, they use all forms of fatty acid solutions today. usually have an onset of action from 15 to 45 minutes, but it depends on how long they hold it in the mouth before swallowing and the solvent used. If it's a true tincture, ethanol is about 85%, and the onset of action is much quicker than something in a fatty acid solution. The other problem is most of the instructions on the packages today follow some other pharmacopoeia, not the USP. They misbrand tinctures, which are not ethanol-based solutions. And the confusion comes when people describe their effect, the onset, and they're using the term tincture, and it's just not all the same. Buccal absorption is placement between cheek, lip, and gum. Dosage forms include a troche, a film, and an oral dissolving tablet, an ODT. They have pouches. They have a number of different delivery systems, but generally placement in the mouth, you can get the least amount of saliva production, which allows for more oral mucosal absorption and less going down the hatch and turning into an oral route of administration. Onset of action is typically 3 minutes to 15 minutes. And again, it's variable based on the formulation, with the duration up to 8 hours. Challenges facing the patient or their practitioner when recommending a route of administration is that products in any category can be very different in formulation and content. So this makes already a complicated product delivering medication even harder to guess at unless you really understand the formulation and the actives and whether they have been mechanically or chemically modified, which currently many of the active forms in the market now can have chemical or mechanical modification, which will change their bioavailability substantially. You know, a typical oral dose of an oil-filled CBD 25 milligram capsule will be around 16%, but you can increase that bioavailability, changing it chemically or mechanically by making it a nano particle size to greater than 90%. Onset of action is nonlinear for cannabis. It's biphasic and it's dose dependent. So it's a real challenge unless you follow some of the rules that we'll talk about in a second. The genomics of the individual have an impact. We talked a little bit about route of administration, and then what are the major APIs, the active product ingredients or pharmaceutical ingredients that are in that particular recipe, because multiple phytocannabinoids can have an influence on all of the phytocannabinoids in that mixture. It's important not to categorize clinical outcomes based on route of administration and that particular formulation. So this is an example of how much we don't know. This is a 30-year-old having 8 seizures per day on 4 different medications. He went to a dispensary and was recommended a 3-to-1 ratio, CBD to THC. So that would be 30 milligrams of CBD, 10 milligrams of THC, no terpenes, in MCT oil, and the cultivar was Diamond OG. This patient became seizure-free in around 24 hours and stayed seizure-free until his next refill, when he went back and asked for, can I get a 3-to-1 sublingual solution, 40 milligrams per mil? Well, the dispensary bud tender gave him the same looking product. If we look down at the phytocannabinoids down here, most common things that are listed are CBD, THC, maybe the acidic forms of both of those, but typically CBN. Just 3. And if you look at these, they're almost identical. But that particular extraction product from lemon haze allowed or did not control his seizures. And again, it came from 2 different cultivars. The dispensary, the bud tender that was in the dispensary also knew that because he was an one of the extractors, that they had changed their cultivar, and he was able to re-extract more Diamond OG and get this individual back into control from the same material. I don't know if the patient was able to continue to maintain that, because the cultivars of batches tend to change based on where they are produced. So you wonder how an adaptogenic herb can have an effect on so many conditions. And this is only a partial list. I've highlighted the conditions, starred them based on the conditions we see most frequently in our Huntington Beach clinic. Most states that have a medical marijuana program will have a list of qualifying conditions and allow a practitioner to recommend cannabis therapy and have regulations in place to protect their license. States with recreational programs do not require a qualifying condition for cannabis access. So if you've done any reading in the cannabis space, the National Academies of Science and Engineering and Medicine published their first report in 1996 on the medical evidence of cannabis following California voter approval of Prop 215, allowing the medical use of cannabis. In January of 2017, 18 years later, they did an extensive review of the literature and focused only on human literature and did not include other basic research. They looked at over 10,000 research articles and broke down the levels of evidence based on conclusive and substantial and so forth. What they found is that there was substantial evidence for the clinical efficacy in chronic pain in adults, as antiemetics in the treatment of chemotherapy-induced nausea and vomiting, and improving patient-reported multiple sclerosis and spasticity. Now, in October of 2022, the first study of its kind in the United States was published. It was a multi-brand, IRB-approved, randomized controlled trial to evaluate the effectiveness of non-prescription CBD products currently on the US market. If you hold your phone up, you can get a picture of this QR code in the upper right-hand corner, and it will take you to the URL of the actual article if you'd like to take a look at it. So the ACEs study or Advancing Cannabis Education in Science, was a 4-week open label, randomized with a waitlist control arm of 2,820 participants aged 21 and older with prior symptoms of anxiety, sleep disturbance, or chronic pain. 2,704 of them were randomized across 13 CBD products currently available on the market, and 296 were randomized to a waitlist control. Primary objective was to document a change in well-being from baseline compared to the control, and secondary is to document a change in pain, sleep disturbance, and/or feelings of anxiety from baseline compared to the waitlist control. Patient-reported outcome measures were collected at the end of each week for 4 weeks using validated surveys addressing quality of life, anxiety, sleep, pain, and adverse events using these validated measures. Here's a picture of the products that were utilized in the study. I am particularly fond of Troche, but I loved that it was up against Charlotte's Web. You can see here the spectrum type, broad versus full versus isolate, and the different formulations that were used by the different companies that were included. This is a list of 13 products that were used, their dosage form, and the APIs and route of absorption. There was 8 that used ingestion, 4 that were sublingual, and 1 that was buccal, as well as the CBD, as well as a couple other minor cannabinoids, and if there was any THC at all measured. Remember that from this slide, full spectrum, there were several products, 5 in fact, but there was only one of the 5 that actually showed a measurable amount of THC. So just because it says full spectrum doesn't mean that it's going to contain a measurable amount of THC. So looking at the impact on well-being and anxiety, taking any CBD product in this study led to significant improvements across all health outcomes relative to the waitlist control at each week. So on the left, we're looking at well-being score. Here's our waitlist control, and here's the improvement. Mean anxiety score, waitlist control, and improvement. Looking at sleep and pain, similar. There was improvements across all health outcomes relative to waitlist control. Excuse me. Looking at the results, largest improvements occurred in the first week of use. Participants experienced a 71% improvement in well-being on average. I don't know why my computer's deciding to change things for me. And then 63% with anxiety noticed a clinically meaningful improvement, 61% with sleep difficulties, and 47% with pain. I realized that these formulations were really not designed specifically for sleep or anxiety or pain. They were a general CBD product. Adverse events were reported in approximately 10% of the participants, and this lists that frequency and number or the type of adverse event and the number on the right of each one of these columns. So let's look at pain in older adults. Up to 50% of community dwelling and 80% of nursing home residents complain of pain. Pain affects 80% of patients greater than 85 years old. The common causes of pain we're all familiar with. Pain leads to decreased functional status, increased falls, depression, anxiety, agitation, interrupted sleep, and poor quality of life. Typical adverse events of the typical pain medications that we use can cause falls, can cause sedation, confusion, constipation, incontinence, retention, many drug-drug interactions. There's addiction or tolerance, and the list goes on. The CDC reported the 12-month period ending in April of 2021 that there was over 100,000 fatalities from an opiate-related overdose. So this is Israeli study was using Tinkum Olam products. They utilize bud or inhalation routes of administration very commonly in Israel. In this prospective study of 2,736 patients greater than 65 or equal to using cannabis between this period of time, the indications were pain and cancer. Results after 6 months of inhaled cannabis, which was over 1,000 subjects, 93.7% reported improvement in their condition with a drop of their NAS score from 8 to 4, which is pretty typical in the published literature, about a 50% reduction in pain. Number of reported falls was significantly reduced. Most common adverse effect was dizziness and dry mouth. And after 6 months of cannabis use, 18.1% decreased or stopped opiate use. Cannabis use in neuropathic pain. A meta-analysis by Muki looked at 16 studies with 1,750 participants, some using commercially available products. Nabiximols is the generic word or term for Sativex, which is a approximately 1-to-1 oral mucosal solution that is approved in over 25 other countries, still has not been approved in the US. Nabilone, dronabinol are both commercial products, Schedule 2 and 3 available in the US today, but concluded that cannabis-based medicine may increase the number of people achieving greater than a 50% or greater pain relief compared to placebo, and cannabis-based medicines have probably increased the number of people achieving pain relief of 30% or greater. In a study that we did out of our clinic, published in Frontiers in 2018, it was an observational longitudinal study over 12 weeks with 49 subjects with a primary diagnosis of chronic non-cancer pain. We used the buccal route of administration for standardized cannabis extracts. We call it a troche. The onset of analgesia was reported between 5 and 40 minutes with an average reduction in the pain intensity numeric rating score of roughly 5. There were 31 subjects using opiates, 26 of which reduced or discontinued their use without any reported symptoms of withdrawal. One of the subjects being or using only CBD, and 100% reported feeling an improvement in a global rating scale. In a group of rheumatoid arthritis patients, they did a randomized double-blind placebo-controlled 5-week study using Sativex, the 1-to-1 oral mucosal spray produced by GW Pharma, and showed a significant improvement in pain on movement, pain at rest, and sleep using those 2 measures. There was no effect on morning stiffness, but baseline scores were low. Adverse events were mild or moderate, and no patients withdrew. Ming on 21 published a patient-reported outcome in those consuming medical cannabis in a prospective longitudinal observational study of chronic pain patients in Canada. His results showed that cannabis users reported using opiates decreased by half from baseline at 12 months, and pain intensity, pain-related interference scores were reduced, quality of life and general health symptom scores were improved compared to baselines, and that was all statistically significant. So cannabis can have drug interactions, and the main interactions are surrounding phase 1 elimination. The more than 60% of prescription medications today are metabolized by the CYP450 system, and all phytocannabinoids can inhibit certain families within that system. I've listed the most common is the 2C, 2D, and 3A families. CBD is the strongest inhibitor of all the phytocannabinoids studied to date, but they can also be a mild promoter. They don't inhibit, and so the main important thing is a lot of the data has been done using concentrations or doses in vitro that are 10 to 400-fold higher than super therapeutic concentrations than what's actually clinically used. So most references now are including, because Epidiolex, a CBD product, is now FDA approved, they've started including both THC and CBD in the drug interactions. I particularly like how Facts and Comparisons and Lexicomp has done a good job of that. ProjectCBD.org is a great reference for healthcare providers as well as patients. And I recommend you take a look at this and the science behind what adverse reactions can and drug-drug interactions can involve based on real products that are out there and fairly good studies. There's more and more that are coming out. The most recent one that I've seen involved digoxin actually inhibiting its metabolism and getting an elevated level from THC. So general rules of starting doses. It's always good to start low and go slow, because at some point there is a lower dose that's going to get a patient a beneficial effect before that changes and you lose that benefit. And then at a much higher dose, possibly you'll again get a benefit. In our clinic, any patient that's cannabis naive always starts with CBD, a minimum of 1 to 3 days. And we see whether that patient has any benefit, whether they're using it for anxiety or pain. You don't tell them to change any of the medications that they're on. You just say, add it and let's see what happens. And then once CBD's on board, then you can add THC if you need to, generally at low doses, starting between 1 and 2.5 milligrams. Remember that the acidic forms of THC generally do not cause intoxication, only the neutral forms. And the route of administration will also have an impact based on whether there's first pass metabolism or not. For instance, inhalation, you'll only get about 10 to 20% of a given dose of the THC component converting to the first metabolite, 11-hydroxy THC, which is typically 3 to 6 times more potent in its intoxicating effect. When you take something orally, you can get 100% of that THC being converted to 11-hydroxy. And so depending on the route of administration, you can have huge differences using the same product. Cannabis has a biphasic action, like I talked about, so there's always a response at a lower dose. Remember that CBD is an antidote to THC intoxication. And that's one of the reasons why we always start someone on CBD before they will try THC in any combination. The certificate of analysis, this particular one is from the troche product that was in the ACEs study. And this is a C of A, and it provides these details. What's the cannabinoid profile? Is there mycobiological contamination, mycotoxins? Is there residual solvents? What is the terpene profile? Is there any pesticides or heavy metals? These are the things that are important to know about any product that you're considering either recommending or patient ever buying. If there isn't a C of A accessible from that product for that batch, then that's a product that you should never buy or take. The purpose of the C of A is to make sure that what is on the label is there, it's safe, and it's contamination free. These are organizations that provide great information. Society of Cannabis Clinicians is probably one of the longest ones. But all of these organizations, these are the current links that you can get, are a great resource for continuing education. Many have modules that you can go through, and now I think the Society of Cannabis Clinicians even has a certification program that's relatively simple to go through and obtain to give yourself a good comfort level when you step into the space of answering all your patients' questions, which they just keep coming. Seems like everyone's going to have to engage in this space if you really want to help your patients. And that's it. Thanks so much. And I survived without coughing too much.
You did good. You did good. So we have some things in the chat. Some questions. Do they have rectal suppositories? Is that a good way to use it?
I find that they're fabulous. But then I'm using a pharmaceutical base. I use PCCA's MBK base. If any of you docs work with a compounding pharmacist, MBK, I think does a very good job of delivering the phytocannabinoids rectally. And one of the nice things about it is there's in any given equivalent THC dose, say 100 milligrams of THC. If you took it orally, they would get a certain effect. If you take it rectally, they're going to get about 30% of the intoxicating effect of that dose. So that's kind of an average number you can use. I use suppositories, CBD suppositories I make for a company, and they use them for female issues. They're delivered vaginally. MBK base can be vaginal or rectal. PMS, endometriosis, the pain associated with it, they work fabulous.
Okay.
I'm not able to, oh, there we go.
You can't see it? Okay. Here in Pennsylvania, the MD is a qualifying provider, but the script is written by the PharmD.
There isn't a script written. Wait, and PA pharmacists are involved.
Right. Okay.
What is the question?
I'm not really sure. Mary, is that Dr. Southard? That's your question?
No, there wasn't a question. It was just in reference to, the qualifying provider doesn't really recommend the dose. It's the PharmD that recommends the dose, which is basically, I think, a lot of states.
Well, there's not many states that still or allow a pharmacist to get involved. There's still states that the Board of Pharmacy will attack a pharmacy and pharmacists if they put CBD in their pharmacy today. So what was it, Connecticut? Maybe Dr. Block can chime in, but the East Coast got or kept the physician-patient connection, or at least healthcare provider being able to touch the patient with guidance, rather than, California, which tried to do everything possible to prevent a prescriber from guiding a patient using cannabis. So it really depends on the state.
Right.
I wouldn't go East Coast there, Kent. I'd say that Florida, from its inception, actually mandated that a physician was there to certify. Again, just as a point that's not really a moot point, cannabis can't be legally prescribed, and that's a key word anywhere in the country,
Right.
be Schedule I DEA designation. So in Florida, the physician is central to a patient access through what are called certifications. The initial visit done in the same room, and you get telemedicine, especially during COVID. That's sort of adjusted the way patients are seen in all aspects of medicine. So let's just say that I think the point Kent's bringing up is that Florida still values the importance of a physician to be the I can't say the facilitator here, but the determinant of a medicine being treated as a pharmaceutical, where those states that are either going recreational or even issues now with gray market things like Delta 8, which we didn't get too much into, that's intoxicating. That's all something that hopefully a legal medical market in a state keeps physicians central to it. And MDs and DOs, by the way, in Florida are the only two docs recognized for that. And naturopaths, who bring a lot of talent to the space because of it being a plant, are not recognized in their full capacity like they are on the West Coast states and up in Canada. So here, if a naturopath comes here, very often they're doing a dietitian type roles, hospital-based things, nutrition-based things, but are not an eligible physician to see patients. And in comparison to that, last I looked, in Arizona, 80% of all the certifications there for patients were done by naturopaths. So every state's doing its own experiment.
Thanks so much for that, Jeff.
Thanks.
There's a question, what's the best product to use for lower back pain with radiculitis, like severe sciatica? It really depends on the individual. I can't stress this enough. I would approach this patient first with hemp-based products, getting them, not changing any of the medication that they're on. That's a key start. Adding a product. I can tell you that, for instance, a troche, which is a buccally administered unit dose form of hemp, CBD, you could use 20 milligrams 3 or 4 times a day, buccally, and you would see how that helped. If that wasn't adequate, then you would have them consider adding THC if they were in a state that allowed them to have access to it, starting with you know, a 2.5 to 5 milligram dose of THC, as long as there's CBD on board. 2.5 to 5 milligrams will get a non-naive patient possibly inebriated. And so dosing is always, if you're adding THC, always start dosing in the evening or some time point that they can take it and not risk needing to drive. And if that was too uncomfortable, making sure that they had CBD to rescue them. There is nothing that THC is, just like a panic attack. People with a panic attack feel like they're going to die. Well, you can take enough THC to cause that same type of an effect. And that effect is not going to harm the patient. It's only going to last for as long as, you know, that particular dose, their elimination system, you know, they'll get through it without any sequelae. And you just need to make sure that if you're starting someone on THC, they understand that there's no reason to call the ER. It's going to pass. Just drink plenty of fluids and relax.
Any interaction between cannabis and opioids?
Well, cannabis doesn't suppress the respiratory center in the brain. So there is an interaction, and what's beautiful is it generally will give a better quality of life, better pain control, and in my experience, lessen the likelihood of escalation or tolerance with opiates. Generally, we get about a 50% reduction in patients that are chronic pain patients, and we start incorporating cannabis. If CBD doesn't work, full spectrum CBD doesn't make it, then many need to go in and get a,
It's true.
you know, a 1-to-1 ratio of something with THC in it. So some people do really well on CBD and some people don't. Some people need a lot of THC in order for it to work. And, you know, it's just their genomics.
Like anything else, right?
Yeah.
Pretty much. Okay.
Will you give the products you use for some of the most common issues a family practice will face? Again, you know, I'm the inventor of the trochee delivery system, a patented buccal delivery system. And for a hemp-based product, it's absolutely remarkable at a 10 to 20 milligram dose how you can get benefits in a patient with anxiety, panic attack. I've taken people off the ceiling in under 7 minutes with a 20 milligram dose of CBD in the, you know, in the buccal route. There was a study done in South America recently that I probably could find and share with you. I have a whole section on talking about fibromyalgia and some of the literature surrounding cannabis and its benefit. There's, you know, very simple, very low doses that were used in the particular study I'm trying to remember, that were used in a sublingual oil-based solution. And they got remarkable results in the surveys that they used in these fibromyalgia patients. You'll find many times that a patient that is not sleeping well and has anxiety, if you use CBD and it helps with the anxiety, they get better sleep. We probably have around 40 to 60% of our patients that use CBD alone for sleep. So you don't need to have something else added to it. Can it interact with supplements? I guess it could if you're taking big enough doses. You know, some of the dosing for some of the childhood seizure disorders, you know, get up above 20 milligrams per kilo. I mean, I've heard people going as high as 50 milligrams per kilo, which is just a massive dose. Typically, we're dosing in the real world, not dealing with those genetic disorders, you know, in the well under 100 milligrams is a single dose, and many times in the 5 to 25 milligram dosage range. It's, you know, we use a lot lower dosing than a lot of the studies are using. So again, you look at how the products are metabolized. You know, we know that clobazam, definitely, because of its active metabolite, you're going to have to lower the clobazam dose on a patient substantially. But all this stuff is in the literature, so all it takes is a quick look.
And can I add something about dosing a second? Because I know
Yeah.
you used the very familiar phrase that's popular about start low and go slow. Most of the evidence-based data is based on studies that came from the first 40 of the last 50 years of studying cannabis and THC. And not surprisingly, there weren't as many concentrated chemovars as there are now. So most of that evidence-based data is a little bit skewed to say that, yes, in low doses, it works for certain things. High doses seem to be more, not just acceptable, but more efficient for neuropathic pain and cancer pain. And if you're getting into other stress disorders, true PTSD, not a diagnosis of convenience, but true PTSD is determined usually by a trained psychiatrist. So with the exception of those things, most everything else about that start low, go slow has a sensibility about what is the optimal dose goal. And that goal is to ensure that both a cannabis naive or a cannabis tolerant savvy patient achieves the same safe and effective outcome where the benefit clearly exceeds risk, and that you're not just trading off one problem for another. But then there's the optimal outcome goal, which is a little different. And that actually is to ensure that cannabis's impact on the endogenous receptor system stays consistent with what the system's purpose is, which is to maintain a physiologic balance. And that's why it's there in the first place. So if you go off the deep end, you can actually disrupt balances by pushing cannabinoids where they probably aren't naturally meant to go. And so staying within what the purpose of the endogenous system is there for in the first place, I think is an understanding that a lot of physicians haven't quite grasped yet into their dosing regimens. And that's just my own little editorial comment. Start low, go slow is the brilliant phrase you use. Thanks, Ken.
Yeah, as always, Jeff. Does CBD slow reflexes? THC is definitely documented, again, in the neutral form, but CBD typically doesn't unless you're one of the really sensitive people that can feel like they've gotten 50 milligrams of Benadryl, and some patients are extremely sensitive to CBD. Even I've had one with very low doses of CBD show clinically significant orthostatic hypotension. So they're all out there. There's outliers, but the majority will not show CBD slows your reflexes.
Does cannabis in general affect driving?
Say that over again.
Does cannabis affect driving?
Hemp-based products, I would say generally, if they've been properly labeled and they meet the hemp definition, they shouldn't. But those extreme, there are clinicians, my colleagues, that are looking for ways to help patients in skilled nursing facilities that have cognitive decline, including Alzheimer's. And we're trying to come up with dosage forms that will be able to deliver to that patient at least 2 milligrams of THC. So it has to be kept below 0.3% in order to fall under the hemp guideline. So we are doing some manipulation, in 2 milligrams with, 8 milligrams of CBG or CBD. That may be sedating for someone and could affect their ability to drive. So you got to know about which product you're talking about.
Okay, thank you.
Cannabis intoxicating delta-9 THC can add sedation. Oh, that's Dr. Block. Okay. You already talked about that. Finally, CBD is known to impact cytochrome P450, potentially impacting the half-life of anticoagulants, right? in particular warfarin. Can you OD on in CBD on CBD? OD meaning
Overdose?
no, again, phytocannabinoids don't impact the respiratory center. You can take enough to possibly cause severe diarrhea and some of the other adverse events that are listed on the typical adverse list of what cannabis can cause, but no. For driving, blood levels do not necessarily correlate with the degree of impairment, that's for sure. Cannabis does not impact driving. Studies at the University of Iowa driving simulation labs show drivers perform with extra caution by often driving slower than normal and showing an inability to stay within a lane. Cannabis does impact driving, right? So again, THC is going to impact driving. CBD is not for most people. Are there any books on the subject? There are a number of them, and I will get that list and provide it to you guys. I can do that for you, Bill. I'll send you a list.
Okay. Please do. We'll send it out. The news, on one of our weekly letters. Dr. Richwine here.
There's a question by WR. I'm a PA provider. Each medical dispensary has either a pharmacist or a physician to consult patients. MD or DO certify that a patient has an approved indication. Got it.
Okay.
ME, the doc certifies based on condition. The dose is done in dispensaries here by the PharmD. That's how it should be. And it's unfortunate that most of the states don't have this relationship. It's just a shame. Can CBD be used just for health maintenance? Absolutely. Keeping your endocannabinoid system in good shape is just as good as I compare it to using a good fish oil. If we want to use CBD to help with sleep, how many hours should it be taken before sleep? It really depends on the individual. If it depends on the components of what's keeping them asleep. Is it pain? Is it anxiety? Is it a combo of both? Good sleep hygiene requires, go to bed. Bed isn't the place where you watch television until you pass out, things like that. But in general, we have a sleep product with melatonin in it, and we will tell a patient, take it 30 minutes before you go to bed. Some will be ready to go to sleep in 15 minutes. Others won't be ready to sleep for a couple hours. It just depends on the individual. What is the Delta 8 strain that is being sold commercially? Well, Delta 8 is a phytocannabinoid that's being extracted and concentrated. It's just Delta 8 THC. So that is, that's really, there's several, even Delta 10, there's companies out there doing things that just, aren't right. And that's one of the products that some states are trying to prevent access from on the hemp, based side.
Can I give a little comment on Delta 8 a moment? Because
Certainly.
Delta 8 occurs in incredibly tiny little amounts in the natural plant.
Yep.
But what happened, and this is political, and it's actually an interesting process. The 2018 Farm Bill you mentioned was what made marijuana get redefined so that hemp would contain a strict definition that it would have less than that 0.3 amount of Delta 9 THC, which is the plant's really only practical intoxicating molecule. Well, this other relatively rare cannabinoid that's also intoxicating, Delta 8, is not practical to try to farm so much hemp that you can extract it right from the plant. So what's happened is that with the 2018 Farm Bill, all of the states now are farming hemp, but they're not farming it for the traditional textile. They're farming it for CBD or cannabidiol, which 2 and 3 years ago looked like it would be the new wonder drug. So as a result, the prices come way down and there is a national glut of CBD. Well, I'll tell you, I'm a chemistry major from Emory before medical school, and it's not hard to know when you expose it to certain acids. Now, this being CBD, that is chemically processed with an acid process, it can be turned into Delta 8 THC synthetically. And that's how come, because of the glut of legal through hemp CBD, now it essentially is, take this for what it is. I know the chemistry. It's a designer drug now that has declared itself through a gray, not black market, but a gray market, and that it's being sold to anybody and everybody, including 11-year-olds in gas stations around the country. That's not good, and I'll tell you why. We know a lot about the other common intoxicating chemical, that's Delta 9, that's in marijuana, but the hemp field, through an unintended consequence of that Farm Bill now, has found a way to sell something that people want, something that's intoxicating. The difference is we've got zero evidence-based data or information on what happens to people when they consume Delta 8, other than they get high. In similar ways, it appears to what THC does, but it's relatively more concentrated because it's coming from a processed oil and staying one. It's coming from CBD and made into Delta 8. And it also then is put into things that are taken not necessarily sublingually like your troches, but are ingested through gummies and the sort, which then your liver the same way converts it to hydroxy 11 THC, which is roughly 3 and 4 times stronger and lasts 3 or 4 times longer than Delta 9 THC. So a little old lady taking it could be out for the count when she doesn't realize what she's taking, because it's usually not packaged and labeled responsibly in a gray market economy. So that's my little editorial comment about how it's really not derived directly from the plant at all, but synthetically constituted as being something else that is intoxicating. Thank you.
Absolutely. Yep, you can make THC, all of the different isomers using CBD.
I want to talk. Hey, thanks, Dr. Block, for sharing the.
Yeah, thank you for being here, Dr.
I
Block.
see a hand up. Michael,
Hey, wait. Oh,
you're on mute.
when can I talk?
Move your cursor around and click the. Can you let him off, Bill?
I'm not
Michael,
sure.
Gerber?
Oh,
I can ask him to unmute himself. I'm not sure if I can do it, so. The bottom left, Mike, the very bottom left there.
it says
The
he's
screen where it
unmuted.
says-
It looks like you're unmuted.
There you go. You're good. Can we hear you now?
You're good to go.
Go ahead and talk, Michael.
He is talking.
So
Well,
now I,
I don't hear you.
Says he's unmuted, so.
Sorry.
While
about
we're
that.
getting Michael on, I just want to make a comment about the Troche products and the patented delivery systems that have been developed by Kent Crowley. They're pretty incredible. I run a pain clinic in West Virginia for about 40 years. Nearly all of my patients, we recommend some type of cannabis like CBD. Usually CBG is, becoming more of a factor. But when you talk about delivery systems, it's the Goldilocks things. It can be too fast, it could be too slow, or it could be just right. If you're doing the inhalation, vapors, whatever you're taking, so you get it fast within 3 minutes, they can become habitual and dependent upon it, and that's not always too good, especially if you're blowing hot smoke in your lungs. And the other way of, if you're in real discomfort, either anxiety or pain, and you have to wait 45 minutes to get a result, that can be a long time. And with the troches, with the buccal absorption, it's so consistent and quick and easy that it seems to be just right, the Goldilocks just right stuff. So in 10 to 12 minutes, you can usually resolve definitely the anxiety issues and the pain issues. So anyway, I just want to put a plug in for that because I recommend the Troche products to all of my patients. And usually once a patient starts to use it, they don't find anything better. It's something that works well. So thanks, Kent.
Thanks, doctor.
Okay, are you on now, Michael? Still no, huh?
He may not have a speaker attached to his computer.
Well, because it says he's unmuted, so. Okay, maybe if you could type in your question. Type
Can
in your
you
question.
type in your question, Dr. Gerber?
While he's doing that, Kent, I wanted to find out what you think is the regular administration just for health with your regular troche and then the troche with melatonin. What's the level of administration and how much do you think people should do for insomnia? Depending on the level of insomnia.
It really depends on the individual. Insomnia can be all over the board. I have some people that take 3-4 servings and which are 10 milligram in that particular product. That's the bar form, which
Right.
is being moved to the unit dose form, which I have a box here that I could open and show you. This is the new
Oh, wow.
unit dose form. So it has individual
Okay.
dose troches. You can pop out, you can take half or one. They're 20 milligram dosing. But
And
10 milligrams for most people is what I would recommend. I mean, if you're exercising, doing it, and you're doing heavy exercise and you want to recover quicker,
20.
taking 10 milligrams of a troche an hour before and right after workout, we've shown in a double-blind crossover trial, at least 4 of the 9 subjects that completed the study that were, elite level CrossFit practitioners. They showed measurable improvement in recovery and in energy production.
What about expiration date? How long does your old troches go past expiration date?
Well, we have 3 years stability in the old form, and we're currently doing a 3-year accelerated study in the unit dose form, which we expect to be 3 years as well, at least.
Okay, thank you.
The nice thing about this because they're temperature sensitive, is now it can melt, reform. You just lay it on the counter and it will solidify. It's still uniform in its composition. So it is now eliminated the problem of delivering trochees to Phoenix when it's 120 degrees.
You have some other forms though, Kent, right? You have a patch and you do have some pills, right?
We have a capsule that's using nanotechnology. That's an oral capsule, and we have a patch. We haven't remanufactured the patch yet because the FDA is coming down on any company that is using a product like lidocaine, which we have in ours, lidocaine and menthol, that has a monograph associated with CBD. They're sending them warning letters. So we haven't been able to figure out how we can put that on the market again without getting an FDA warning letter. Really sucks. It's the best patch on the market. People beg for that patch.
Yeah,
and,
we used a lot of them, so.
and we don't know how to avoid the FDA attack. I mean, this is really sad. They're supposed to be protecting, patients. All they're doing is preventing access.
I don't know if this may help, but there's a lot of legalities into private membership associations, but a lot of people are going that route to avoid stuff like the FDA. Have you and your company checked into that?
What do you mean?
You basically sell a subscription, and that way you can get patches to your patients because
Wow.
they're part of a private membership.
I didn't know you could do that, but I definitely will look into it. Thank you so much for that, Joel.
Definitely. PMA.
That's wonderful. Thank you.
You bet.
All right.
I mean, we've had to go through almost a year of retooling the entire website because of the requirements that you can't make any claim. And we have studies for Latroche, and we're if we use one of the trigger words, insomnia,
Right.
pain, I can't even use oral mucosal.
Yeah. Paul Saladin was one of the first people like 20 years ago in farming that started to go full blown organic with his farms, and they were coming after him hard, and so he started the PMA, and that way he can get his organic pigs or his organic beef out to his membership people, and that was the way he took on the government. It's pretty powerful.
Awesome, because we've focused on prescribers now because Troche does a great job when it's prescriber directed therapy, and so we're closing the way that you can access, but that membership thing may be a real winner for us to get around the challenge. Thank you so much, Joel.
Definitely. We'll keep in contact, and I'll send you some more information.
Cool.
Okay. Anybody else have any other comments or questions? Michael, I'm not sure why we can't get in touch with you, but send me a text message and I'll try to relay. So, okay. Anyway, thank you all for being with us. Dr. Block, good seeing you again. It's been a while. Thanks for your input. Kent, you made it through. You did fine. You did a great job. Thank you for everything that you do. Thank you for what you do for us. And next week, we're gonna have David Kahn on. David, what does he do? He does EMF, some sort of EMF equipment, right? So,
PEMF, and I think he's a chiropractor.
yeah, so.
Pulsatile electromagnetic field therapy.
Yeah, I know. He's got like beds and pillows and all sorts of Hazarai.
Great stuff.
So,
It's the new future.
yeah, me, I'm too left brain to
Old-fashioned.
know what that stuff is. So,
That stuff's old technology. It's been around for 50 years. There's a lot of
yeah, well,
science behind.
so I gave a talk last night for Dr. Alasso's group on methylene blue, and that's old technology too, but they kind of got the. I tried to put it in perspective though, so I gave, this is what it does and this is what you use it for. Bing, bing, bing. It didn't go well. They took over after an hour, and then they were talking about all sorts of things. So like as they usually do. So that's next week. We have Dr. John Casey the week after that, and Dr. Carol McMakin, who's frequency specific microcurrent, and she's going to talk about Ehlers-Danlos syndrome on May 30th.
Maybe we can get Dr. Block to give a talk. He's an author now of 3 textbooks, or at least portions thereof. And isn't one becoming or being released here shortly, Jeff?
Yeah, and actually the third one this year also. And there was somebody who in the chat asked about other textbooks in this. There's a lot of magazines. There's a lot of sort of industry sponsored rags, but not really many textbooks. So in 2020, I did a chapter on cannabinoid receptors and medical cannabis that was in a book called Advanced Therapeutics in Pain Medicine. It's a real book. There's 24 chapters. It's the integrative approach to treating pain, and it's usually chronic pain in that respect. Then another 2 weeks or so, or another week from now, the first total book, actually, this one involving cannabis, is Cannabis Chemistry and Biology Fundamentals. The editor is Mahmoud El-Soli, who runs the federal government's farms in the University of Mississippi at Oxford. So he's technically the Fed's grower for the last 40 years, not a kid in Colorado. And the third book is a pharmacy textbook called Brody's Human Pharmacology. It's the 7th edition. I've rewritten actually 2 chapters, the first one on cannabis therapeutics, but I looked over the book and I told them I'd do the cannabis therapeutics chapter if they would let me also rewrite where cannabis is also mentioned in their chapter on drugs of illicit use and abuse. Otherwise, you can come across as being too much of an advocate if you don't approach it from the fair and balanced way. So those are 3 different textbooks, 2 of which are coming out in the remainder of this year. So thanks for the plug, Kent. I make no royalties.
Yeah, there's the advanced therapeutics and pain medicine. And then Goldstein, Bonnie, if you don't know her, with the Ethan Russo forward. This is Cannabis Revisited, or Revealed, excuse me. And that's another recent publication that's goes over a lot of stuff.
Where can we get those books from, Jeff?
What is it? So the first book is CRC Press. That's the Taylor and Francis group. That's a fairly solid second tier medical publisher. And while neither is the Harvard Press or Lancet, the other one coming out in a week or 2 is De Gruer, the publisher. It's a German publisher again in healthcare. That's again cannabis chemistry and biology fundamentals. The third book, I'm going to mispronounce it. Evelsier is the publisher of Brody's Human Pharmacology. That has not been released yet, or it doesn't have the release date, but it's supposed to be sometime later in 2023. So I think all of those, if you pulled up Amazon, you could pull up the individual books. I know the one Kent was just showing with the black cover, that's certainly available that way. And I think most of them are all available also as ebooks, so it doesn't have to be that expensive.
Great. Okay. Don't be a stranger.
Hey, thank
right,
you for having
guys.
me back.
Thanks so much.
Okay.
I'm gonna go
Yeah,
lay
well,
down
we
now.
try to have each other's back. John, you got anything for us?
Everything's beautiful.
What-
Thank you.
What's happening in the medical school world?
100% positive times 10. It's outrageous. We got some wonderful, very, very advanced thinking people at the medical school, and they're in line with everything we speak of and everything we do. So they're brave people as well, and they're probably going to pull it off. In other words, they're
Okay.
going to incorporate nutrition research, and all of us are for nutrition and research, and they go way beyond that. They're really osteopaths.
Do you know the
All
name
right.
of the school yet? Have they named the school yet?
The school, yeah, school will be Emeritus Osteopathic Medical School. Maryland is run by a medical system, like you have Blue Cross in places.
Right.
You have Meritus Operating System in Maryland, and they are in such need of qualified physicians that they have decided to start a medical school and train them as they think would be appropriate. And they just have really high quality people in the whole thing. The academic dean, chief residents, family practice, OMT. They're way beyond anything I was expecting.
All right, keep us informed.
Yeah.
Okay. Okay. Anybody else have anything to comments, questions? Okay, thank
Wanna
you
say-
all.
As always, Bill,
here
for
and-
keeping this thing running.
Yeah,
Yeah, thank you all.
we're we're not stopping. So I've actually had a couple of folks making inquiries about maybe doing a hands-on workshop kind of program. And I may actually have a couple of folks coming here to Reno at the end of June, the beginning of July, if anybody's interested. And we would do some aesthetic stuff, probably how to do pellets, things of that nature. So if anybody's interested, let me know, and we'll put it together. I think we're getting
Doc?
ready to, yeah.
Dr. Robin chimed in. You're muted.
You're muted. You're muted, Dr. Robin.
Sorry, I just want to say thank you. I didn't know about this group. I ran into you guys, I think, at an OMED conference in San Diego, and it was very surreal because I didn't know that, they allowed that kind of thing at OMED, and I was pleased.
You want to
and
tell her, John, or you want me to?
I'm saying.
No, I don't
that-
want to get anybody started because I've heard a little bit, but I'll hear it sometime. But I just want to that was that was where I hung out the whole time. I was there just to take an exam, and it was like, oh my gosh, my people are here. And then I lost you again. So ran into Bill somewhere in the last couple of days on LinkedIn or something like that. So I just want to thank you guys for holding the torch. Sounds like you've been doing a really beautiful job, and I'm really happy to meet you and hope to be part of this.
Please
Yay.
do.
Thanks, Laura.
Thanks.
Please do. Thank you for being here.
Yes.
I did have one thing, just one little thing at AMMG. A DO came up to me and he actually apologized to me and said he was in the, I know you don't want to hear it, John. He was at that meeting, and he apologized for not standing with us. So I won't mention any names, but so I guess I felt good. I don't know. It's just, but so that's it. That's all you're going to hear.
All right, guys.
We're
have a good
we're
night.
moving on, and I think, John, we don't talk to Sylvia. I think it's time to maybe start looking to get recertified again as integrative medicine. So, okay, so we've let it sit for a year. I think it's time to get moving.
Yeah,
I would actually be interested in being a part of that conversation if you needed more strength or.
Hey, Laura, why don't you be the
And-
committee chairman and do this?
Yeah, you just
Wait
volunteered.
a minute.
Yeah, okay. I vote.
But-
Anybody
Yeah.
second it?
Wait, what did we
Hey,
say?
Bill, we're
We
getting,
said something
Bill, we're
about
getting the band
starting
back
slow,
together.
Yeah, we're getting the
starting
band back
low
together.
and going slow, right?
Yeah,
I
Yeah,
so
well, we've
second
been-
that.
we've been going slow, so. All right,
Thanks.
so, all right, I'll be in touch with everybody. We'll be here next week, same time, same station. And anybody has anything that they want to present, please let me know. We'll take it from there. Okay? So see you, and I do apologize about last week. I don't know what happened, but the video didn't record, and so we missed that one. But we got this one. So AOSRD.org, that's where everything is. And I'll try and get in touch with Dr. Gerber and see what he had, what he wanted to say, and sort of see what kind of questions and answers we can get for him. Okay. Okay, with that, everybody, have a great night. Thank you for being here, and just take care. Okay.
Hoorah.
Good night. Hoorah.